Good evening, everybody. My name is Dr. Elliot Paul. I'm a urologist practicing in Lake Success, New York. I'm part of Advanced Urology Centers of New York. For those of you not familiar with our practice, we're a large urology group practice. We're located in New York, extending from Long Island, both in Nassau and Suffolk counties. We go to Queens, Brooklyn, Manhattan, and we're a large practice practicing all aspects of urology. Personally, I practice general urology with a little focus specifically in kidney stones, where I get referred a lot of patients for kidney stones from other urologists. And for that reason, tonight I'm going to speak with you about kidney stones, the causes of stones, the treatments for stones, and even how to avoid kidney stones. Some of us are predisposed to stones. As many as 1 out of 10 people will develop a stone in their lifetime, and stones tend to be recurrent in a lot of these patients. We say after their first kidney stone, there's about a 50-50 chance of having another stone within the next 5 years, and about an 80% chance of developing another stone within the next 10 years, which of course therefore makes it concerning for anybody who's had a stone or a family member has had a stone, and it makes concern that they're going to get more stones in the future. So obviously we like to talk about how to prevent them. This is a general information talk, so I certainly encourage anyone on this call who has a serious concern about stones for themselves or their family members to discuss it with their urologist. Within Advanced Urology Centers of New York, there are a lot of capable urologists who manage kidney stones all the time, and any one of us can certainly help you with yours. So with that being said, let's go on to the first slide. So as I mentioned before, about 1 out of every 10 people is going to develop a kidney stone during their lifetime. By the way, I didn't mention, if you have questions, feel free to type them into the chat bar on the side, and I will try to get to them maybe during the talk if there's an opening to do so. Otherwise, at the end, I'm happy to stick around afterwards to try to answer any questions that may arise. All right, so first of all, talking about the kidneys. The kidneys are 2 bean-shaped organs that are in the body, in the back area, really. A lot of people think they're more in the front. They're in the back area, protected somewhat by the rib cage. And what these organs do is that they filter the bloodstream. They filter waste products and extra water that the body doesn't need from the blood to produce urine. Now, what happens when a stone forms is that the urine can become super concentrated with certain minerals that were in the bloodstream. And when they get excreted into the urine, if the urine is saturated with these substances, they can crystallize and develop into a stone. The stone that develops can sit in the kidney and gradually grow. It may not grow. It can sit where it is for many, many years. And in some cases, they travel out of the kidney and go down the ureter being the tube that connects the kidney down to the bladder. And if they get stuck in the ureter, it causes a backup of urine to the kidneys. The kidney may then swell. And when the kidney swells, that causes pain. So a lot of people think that kidney stones cause pain when they scratch the ureter. That's really fabricated. That's not really what happens. But what happens is that because it blocks the flow of urine from that kidney, the kidney can swell and they can develop pain. Now, thankfully, most of us have 2 kidneys. So when one kidney gets blocked, we're not in trouble per se, but it can be very painful or cause problems such as infections, which can turn it into a potentially even life-threatening emergency. So the question becomes, how do we manage each stone? And we're going to talk about that in a little bit. So kidney stones can vary in size. They can be as little as a small grain of sand, and they can grow as larger than a golf ball. Actually, they can fill the entire kidney in some circumstances. That would be called a staghorn calculus. Staghorn meaning that it fills up most of the kidney, or takes on the shape of the kidney. And some of those stones, believe it or not, are actually painless. They just sit in the kidney, they grow for years, and they get picked up incidentally on a scan that might be performed for any reason at all. Maybe if a person's in a car accident and they get a CAT scan and incidentally they pick up a kidney stone, or they may have a drop of blood in the urine, microscopically even, and that can prompt their physician to order a scan. Okay, so now there are different types of stones. There are calcium oxalate stones are the most common type of stone. These form when the body takes oxalate from our diet. Oxalate is in a lot of common foods, such as chocolate, teas, nuts, colas, and lots of other healthy fruits and vegetables. But the oxalate is in our regular diet, but some people are predisposed to stones. So when the oxalate from the gut binds to calcium in the gut, it often will go out with the stool. But in certain circumstances, if there's not enough calcium in the diet, some of that oxalate will get absorbed from the intestines into the bloodstream, find their way into the kidneys, And when they're in the kidneys, they can then bind calcium, which our body can take from anywhere, including our bones, and a stone can develop. So that would be how a calcium oxalate stone can form and create its own problems. The next category is uric acid stones. So uric acid stones are a byproduct of protein or purines. And again, it is in the diet. We all eat plenty of proteins, or most of us certainly do. But some people are more predisposed to them, to these stones in particular, especially people with gout. Gout is a disorder where people have an accumulation of uric acid within their body. Sometimes it can develop into gouty attacks. They can have sores in their foot that are really from a buildup of uric acid there. And various foods with a lot of protein can ultimately end up getting excreted into the urine, where these uric acid stones do develop. All right. Struvite stones are the next category. These are infectious types of stones. So it's commonly in people who have recurrent urinary tract infections, and they can end up developing stones from a breakdown product of the infection from the bacteria, and a stone can form. Frustratingly, the infections are sometimes difficult to clear unless you take care of the stone and get rid of the stone, which can become very complicated because we don't like to operate when somebody has an infection. So it's sort of a catch-22, and it can be very frustrating and challenging to manage. And those stones can actually often be very, very large, and often be the staghorn calculi that we mentioned earlier that can fill the entire kidney in some circumstances. And the last category I mentioned here is cystine stone. These tend to be a rare type of stone, but they run in families. And frustratingly, the people who develop these stones tend to get them very, very frequently, and they tend to recur very often. So who gets a kidney stone? It's fairly equal in terms of men versus women. Maybe men get them a little bit more than women do, but it's common when somebody has a family history of stones, and specifically in Caucasians, it's more common. But inadequate fluid intake. So dehydration allows for, again, the urine to be saturated with the substances that can develop stones. And sodium I look at sodium or salt as the opposite of water. So sodium can accumulate in the body, causing excretion of calcium into the urine, and increase the risk of stones. Sugar can do it as well, but sodium is certainly the bigger one. Vitamin C supplements, certainly in excess, can be problematic and can cause stone to develop. And then certain surgeries, intestine surgeries, or just certain gastrointestinal disorders like diarrhea, if chronic, can predispose someone to developing kidney stones. There are numerous medications that can cause it as well, as mentioned on this slide: diuretics, calcium-based antacids, and certain anti-seizure medications. And then there are certain medical diseases such as high blood pressure, diabetes, and obesity that predispose people to stones. Also, along with obesity comes immobilization. So people who are bedridden break down bones sometimes, and calcium builds up and can develop into stones. I see there's a question about how much oxalate is in foods. So there are contradictions between lists. That is the question that's being asked, and why is it so difficult to determine? And I think part of that has to do with the specific production of a given product. Not all products are the same. Even given fruits and vegetables are not all the same. And I think that there is a lot of controversy as to what really has a lot of it. So, for example, a lot of people say tea, as I mentioned earlier, is a form of oxalate in the urine, or a form of oxalate that can develop into kidney stones. But I've heard very well-respected nephrologists disagree with me on that comment, because they say that all the fluid that's within the tea, it's really mostly water and not so much oxalate, and it's being diluted. So it's not very well understood, and given situations have to be weighed for an individual. The most important thing I tell patients, especially when it comes to the oxalate question, is if you're going to be taking in a lot of oxalate for whatever reason, or even more than you should because you've developed calcium oxalate stones in the past, you should try to hydrate yourself to try to balance out for that oxalate intake. Another thing that, and we'll talk about it later on, but citrate intake. Citrate is a stone inhibitor. It prevents the development of stones, and it's really good for all types of stones. And there's different ways of getting citrate, such as when people have to take calcium supplements for some reason, say for osteoporosis. So I tell them to use the form of Citracal or calcium citrate, because at least the citrate may help prevent that excessive calcium from becoming stones. All right. So because they typically get lodged in the ureter, and they don't have to. Kidney stones can sit up in the kidney, not cause a blockage, and be painless. But if they do get lodged in the ureter, that's when they cause pain. As I mentioned before, it causes a backup of urine into the kidney, and they can cause anything from a very mild pain to severe pain, what we call renal colic, just like when we talk about babies having colic. So it can be a severe writhing kind of pain, cramping back and forth, and it can start up in the flank area, again, the back, roughly the mid back, but it can wrap around the abdomen down as low down as to the testicles in men or to the labia in women. And the pain, as I said, can come and go in waves. If the urine gets infected and it gets trapped behind the stone, so that can be very dangerous. The urine has no place to go, the stone is blocking, and if there's an infection in the urine, that can cause sepsis. It can cause, because the urine can't go anywhere. So now you have this infected urine and it can't get out. So the patients will present with fevers, and that turns it into an absolute emergency. Now that's not, I don't mean that every time somebody has a fever and they also have a stone, it's an emergency, but if the stone is blocking the kidney in any way and there's a fever, we treat that as a true emergency, generally try to drain the kidney within hours, if not sooner, whenever possible. Either with a drain into the kidney directly or putting up a stent, which is a plastic tube that can help drain the kidney. Nausea and vomiting can be a symptom of the kidney stones as well, when there's a backup of urine to the kidney. And some patients will have blood in the urine. That could be whether the stone is blocking or not. Sometimes if it's truly blocking the kidney, there won't be blood in the urine because urine's not even coming from that side anymore. That side's completely blocked. So you wouldn't necessarily see the blood in the urine. And so it could be there could be a misdiagnosis of a lack of stones, because in the emergency room they say the urine has no blood in it, but in fact that kidney is completely blocked and the urine is all coming from the other side. So, but blood in the urine is common with stones, either microscopically or visually. And if the stone is lodged at the very bottom of the ureter, so it's traveled down from the kidney down the ureter to the bladder, it can irritate the bladder and cause the patient to have frequent urination or urgent urination because it's irritating the bladder. See, there's a question about bladder stones and kidney stones and the relationship of the two. Generally speaking, these are two different things. Kidney stones are a metabolic problem, and that's the topic of tonight's presentation. Bladder stones develop usually because somebody's not emptying their bladder well. And if you think about it logically, a kidney stone that passes down the ureter is a very narrow tube. So if it can get out through the ureter, it generally can be urinated out through the urethra in most people. There are exceptions to that rule. They can get stuck in people who have large prostates or in women who have significant prolapse of their bladder. Again, that's a topic in and of itself. But if a person has a real difficult time urinating in general, then a stone could get stuck from the bladder. But otherwise, in general, the difference between bladder stones and kidney stones is actually vastly different, and they're different causes of them and treatments of them. Okay. So as I mentioned, stones of all sizes can cause no symptoms. You can have a tiny stone in the kidney or a huge stone in the kidney, and if it's not blocking, generally speaking, those will be painless. But the converse is true as well. A small stone that travels down can get stuck. I've seen bodybuilders with tiny stones writhing in pain and can't tolerate it because it blocks the flow of urine, and it's just extremely painful and can be. And if somebody can't tolerate the pain, then at some point we have to intervene, even if the painkillers are not doing the job. Okay, so how do we reduce the risk of developing stones? The answer is drinking more fluids. That's generally what we recommend. 2 to 3 quarts of liquids daily, or producing 2 liters of urine per day is really something we'd like to see. That's a lot of urine. It's a lot of drinking. It can be very difficult, but for somebody who's predisposed to stones, we strongly recommend it. Water, coffee, lemonade. Lemonade we recommend because it has citrate. Citrate is highly concentrated in lemons. That doesn't mean lemon flavored drinks, but what I'm referring to is lemonade made out of real lemons. Sodas, in particular, the dark sodas, the colas, they have a lot of oxalate, and they also have a lot of sugar. So we generally don't recommend those. And people who have kidney stones really should find at least water, if not lemonade, as their main drink, if possible. And we see stones tend to develop more commonly in the summertime because of high heat, dehydration ultimately, and people aren't drinking enough in many of those circumstances. Okay, so how do you reduce your risk? So again, it depends upon what types of stones you have, but fluid, most important, and decreasing salt, I think are really, really important. As I mentioned, citrate helps prevent stones from forming. Citrate is in lemons. Other citrus fruits do have it as well. There are places where you can get citrate supplements from. And I tend to recommend that people take citrate supplements in many circumstances, not all, but many circumstances where people do develop stones. You can buy them in various places. Of course, every place is different. There are numerous supplement providers that where they can be ordered. There's a company called Theralogics that sells citrate supplements, but there's lots of them out there. And these can help prevent stones of all sorts. All right. So first of all, if you have calcium oxalate stones, we recommend trying to limit the amount of high oxalate foods, or even eliminating them from the diet. It can be challenging, but it's important. And as someone asked before, correctly so, it is a little bit confusing sometimes if you look online, or even asking your urologist what foods have a lot of oxalate. There are some conflicts, but in general, most of the lists are going to be fairly comprehensive and similar, but they're big lists, and there's a lot of things to avoid. So again, when somebody does sort of cheat on that diet, they should be countering it with some extra fluid intake. So spinach, many types of berries, chocolate, wheat bran, you can read off the slide, all different types of things, rhubarb. Getting in calcium, dietary calcium. So as I mentioned earlier, it's actually paradoxically the lack of calcium that sometimes causes that oxalate to go unattached in the intestines. And because it's not attached to calcium in the intestines, it gets absorbed. And when the kidneys excrete it, it does get latched onto calcium in many circumstances, causing calcium oxalate stones. So enough dietary calcium in the gut can hopefully take that oxalate out with the stool, avoiding its absorption. Of course, too much calcium is not good either, because then it raises blood levels of calcium, and that can also be problematic. So people who take extra calcium supplements should be cautious. It should be done how it's prescribed by their physician. And again, I typically recommend calcium citrate, or Citracal is a brand, because this can hopefully counter the calcium effects in many patients. All right, protein. So too much protein, especially in a uric acid stone producer, is not going to be great. These patients are going to be predisposed to taking that protein, breaking it down into uric acid, and developing a kidney stone. So too much protein isn't great. Again, countering it with some fluid is always a good idea. Avoiding the high salt intake. Again, as I mentioned before, salt being the opposite of water, in my opinion, but it's really doing it by causing calcium to end up in the urine, which can cause more stones. And then I think somebody did ask a question about vitamin C, although maybe it was vitamin D somebody asked about before. Vitamin D is a little bit different because of how it causes calcium absorption as well. But vitamin C supplements, too much vitamin C can cause someone to produce more oxalate, and that can end up in the urine as well. Okay. So we're gonna start talking a little bit about the treatment for stones, and try to give a broad overview of this. But for starters, we obviously prefer for patients to be able to pass their own stones and not need surgery. Surgery should generally be a last resort. So we say sometimes up to 80% of the smaller stones pass on their own. That's a very vague statement, because how do we define smaller stones? So really 2 to 3 millimeter stones have probably an 80% chance of passing if given the opportunity to do so. But what does that mean, the opportunity to do so? That may mean that somebody's writhing in pain for days on end, sometimes weeks, and some people can't tolerate that. And in certain circumstances, we have to go operate. But of course, we'll try to help them get through it with some painkillers and give them time to pass the stone. And even larger stones can pass. I've seen people pass 10 millimeter stones, or even larger in rare circumstances. A patient brought in a stone to me this week that was probably 3 to 4 millimeters, and they actually didn't even feel it. That's unusual, but the patient somehow passed it. But there are medications that we can give sometimes to try to help people pass the stone, and we try to help them deal with a lot of their symptoms as well, to get through nausea. We give the anti-nausea medications or painkillers. So the first line of treatment, generally speaking, is alpha blockers that relax muscles. In particular, it can relax the muscles of the ureter where the stone may be getting stuck. So Flomax is the most common one used for this. As I mentioned, we give painkillers, whether they be over the counter or prescription strength. And we give anti-nausea medications as well. That's not on this slide, but nausea medication for those who need it. Somebody's asking about, is kidney cop good to take? I don't really actually know what kidney cop is. A lot of these supplements they sell on the internet. that people buy. I really couldn't tell you what each one has in it. A lot of them are not monitored by the FDA, and I've been asked many different questions about different things, that home remedies of various sorts, or even things that are sold on the internet in large quantities out there. But whether or not they really clinically make a difference, there would have to be a good study to prove it. And many of these supplements don't undergo the testing and try to get FDA approval to be able to answer that question. Now, as the slide says here, uric acid stones can sometimes be dissolved with medications. That's true. Not usually utilized when a stone is already stuck in the ureter. That's usually for when the stone is in the kidney and we try to dissolve it before it becomes problematic. Once it's already in the ureter and it's blocking, so first of all, there's not great flow of urine there. So when we give them the medication to what we call alkalinize the urine, to raise the pH of the urine and thereby dissolve these acid stones, these uric acid stones, it really doesn't do as good of a job when it's already stuck in the ureter, because you're not getting the urine to go past it as much to try to dissolve it. In addition to which, when you have somebody in pain already, they really can't wait the time that it will often take to dissolve such a stone. So when we need to intervene, there's various, I'm going to talk about 3 broad categories of surgical interventions, and the first of which is the least invasive type. ESWL, which stands for extracorporeal shockwave lithotripsy, meaning outside the body, we're using shock waves to break the stone. So this utilizes x-rays or ultrasounds to first identify where the stone is. In general, we knew that before we got to the operating room, but at the time of the procedure, we need to know where it is real time so that we can try to break the stone. And then we use shock waves or sound waves to penetrate the body, to go to where the stone is and fragment it into small pieces. The ideal outcome of a procedure of this nature is to turn the stone into sand so the patient doesn't have to feel it when it comes out in the urine. Unfortunately, they don't always work. Sometimes it has zero effect. Sometimes it just breaks it into 2 pieces or a few pieces, and the pieces themselves then have to pass. So you can't always get as good of an outcome, which means for much larger stones, this isn't a great option, because for the much larger stones, they have to pass larger fragments, at least theoretically. And so it may make it harder to pass it, and so therefore this may not be the right choice. But there are times that we use it even for large stones. In some circumstances, we'll place a stent, a plastic tube that helps protect the ureter from stones getting stuck on their way down. These are temporary, of course, so they have to be ultimately removed. And therefore, we then need to prove that the stone has been eradicated before we can take that stent out of a patient. So that's something that you'd have to discuss with your urologist if that type of procedure is appropriate for your stone. When somebody asked about whether or not the ultrasound that's used to break up the stones can cause other damage. So the answer is yes. It's rare. The shock waves are ideally aimed at the stone, and it's done in a 3-dimensional fashion so that we're really only hitting the stone, hopefully, or right around the stone. Of course, there's a little bit of an area around the stone that may be getting hit as well, but it shouldn't really be hitting other organs nearby, or even do any real damage to the kidney, although sometimes there is some bleeding from the kidney afterwards, but usually not too bad. We won't do it if somebody's on blood thinners, because the kidney then can bleed, and it can be extremely dangerous because it's uncontrolled bleeding. But there are reports of it causing other problems. There are reports of pancreatitis being caused by shockwave lithotripsy. Again, rare. If there are calcified arteries anywhere in the vicinity of the field where things are being done, we don't do it, because we don't want to shatter that calcium in the artery. So that could be dangerous. So there are certain circumstances where it can be problematic, but in general, this is considered the least invasive form of stone treatment, and it is typically not a very dangerous procedure. But the bigger problem is, will it break the stone adequately, and what will the patient have to deal with afterwards to pass the fragments? The next option for treatment of stones after lithotripsy is ureteroscopy, and we choose different operations based upon surgeon experience, the size of the stone, the location of the stone, and this talk is certainly not going to tell you which procedure you should have. You obviously have to discuss that with your personal physician. But ureteroscopy is a minimally invasive procedure where a camera gets placed ultimately into the ureter or the kidney. It goes through the urethra into the bladder. We find the opening that goes up to the kidney called the ureteral orifice, and we follow that ureter up to the stone, whether it's in the ureter or the kidney. We then ultimately get to the stone or stones, And we can either sometimes just basket the stone. In this picture, although it's a little bit subtle, there's a basket grabbing that stone that's to the right on the screen. Although the stones are green in this picture, I've never actually seen a green stone, but the stones are basketed and taken out of the patient. But in many cases, we first have to fragment the stone. That may have, in this picture, may have been a larger stone before, and a laser was first utilized to break it into 3 pieces, and then we grab each individual piece with a basket to take them out. And this can be done in the ureter. This can be done all the way up into the kidney and take out stones. And again, the urologist has to make that decision together with the patient, understanding the pros and cons of each procedure to ultimately remove the stones. After this procedure is done, there can be some swelling of the ureter where the stone had been and where the scope went. And when that happens, the ureter can close down. If we did not leave a stent, which I mentioned before, stents when we were talking about lithotripsy in certain circumstances. So we typically leave stents after these ureteroscopic procedures, because otherwise, if we don't, the ureter can close down and the patient will end up in the emergency room with pain later on, or in worst cases, a bad infection. And if the infection can't get out, again, they can become septic, causing them to even be in the ICU. And so then a stent or a nephrostomy tube, a tube into the kidney, would have to be placed. And therefore, we generally leave a stent after these procedures for days to, in some cases, weeks, and we remove them later on in the office setting, typically. Somebody asked the question, if someone has a stone, can they pass it without knowing they have a stone? Yes, it has happened before. Of course, it can be very painful, but you may attribute the pain to something else. And so, that is that can be a challenge. Can be something challenging to diagnose if the patient doesn't know for sure, but you have a reason to suspect it after the fact. And if they passed it, you may never know. They may develop more stones in the future. Somebody else asked if I'm taking potassium citrate 60 milliequivalents, or they wrote equivalents, but I believe they mean 60 milliequivalents. Is it okay? So it depends. Obviously, that has to be monitored by your doctor. It can raise the potassium levels in the bloodstream, but 60 milliequivalents has been prescribed in safe circumstances. But potassium levels generally should be monitored, and it should only be done knowing that it's safe to do so in a given patient. So that should be discussed with your personal physician. Now, I mentioned before that the ureteroscopy with the last procedure, we talked about going up and lasering it. But sometimes you get up there and you're in the kidney and there can be some bleeding, or the stone's really big. And as you're breaking it, it almost becomes like a sandstorm. There's just a lot of sand from the stone, and visibility can be limited, and it can be difficult to get the entire stone out. Also, there could be lots of little pieces that you leave, that you shatter the stone into tiny pieces that you can't grab with the basket because they're actually too small to fit within the prongs of the basket to extract them from the kidney. And of course, you worry that if you don't take them out, might they just sit in the kidney and eventually turn into another stone and defeat the whole purpose of why you were there. So it's been something that we've been looking for years, to have some technology where as we break up the stone, let's suck out the pieces. We're up there, but these are such tiny scopes that we're using that really they were very limited with the technology to be able to do more than put a basket through it and grab it. And if you can't do that, then you're out of luck. But now there's some new technologies, and this is not the only company that's made something like this. There's a few different companies that made different types of devices to try to remove the stones more efficiently and more effectively. But this is one with which I have a lot of experience now. It's essentially a vacuum device that works while we're doing the ureteroscopy that we were just talking about. We go up into the kidney, and as we break up the stone, it's sucking out the sand that we're developing as we're breaking the stone. And ultimately, you can suction out even small fragments up to 2 millimeters. So if you break the stone down into really tiny fragments, you can then suction them all out so that the patient really can be rendered stone-free at the end of the procedure. And I'm going to show some schematics of this and even a video in a moment. So here you see a picture of the scope itself. It's a long scope. It has to go all the way up into the kidney, and it can flex into different parts of the kidney in order to retrieve the stones. The older scopes could do the same thing in terms of flexion, but they couldn't suction out any pieces. So we can put a laser fiber through this scope. Again, that was done through all the old scopes as well. Fragment the stone into small pieces, and as we're breaking it, this particular scope is also suctioning out some of the dust, so we have better visibility. It sucks out some blood if it accumulates in the kidney while we're lasering, and therefore visibility is better. And ultimately, when the fragments are down to a very small size, it can even suction out most, if not all, of the fragments if used correctly. Again, nothing's perfect, of course, but this is a nice new technology that really does help with the effectiveness of the surgery. So here we're going to watch a video showing you this particular device. And this is the CVEC device. As you can see, the scope can flex, so it can help us get into different parts of the kidney. So when the patient goes to sleep, these are the two kidneys, and here's some stones within this particular kidney. First, we feed a wire up into the kidney. This just helps guide the scope that we're going to then put up into the kidney. The wire will curl in the kidney, and we can then follow it with the scope over the wire, pull out the wire, and now the scope is up in the kidney. And now we can follow it to find where the stones are and start to use a laser. And here in this schematic, you're seeing the stone slowly breaking. And as it's doing it in the center, it's actually suctioning out tiny little pieces. So it's breaking it and sucking simultaneously, creating a vortex of the water that comes from the outside of the stone. And in this particular one, they're showing leaving some tiny fragments behind intentionally, breaking up the next stone, doing the same thing. Now all the stones have been turned into tiny fragments, and now we go back and suction out all the pieces to try to render the patient completely stone free. Not every case is as simple, but this is a great new technology and a great way to rid a patient as stone free as possible. Somebody, while we're watching the rest of the video, somebody asked if stones can live in your kidney forever, or do they all pass? No, they can live in the kidney forever. I've had patients come to me with films that they showed me from 20 years earlier where the stone was in the same spot as it is when they first came to me, and nothing's happened. And so even though I initially thought I was going to tell them that they need surgery, when they showed me that they had a stone there 20 years earlier that was exactly the same, I decided to leave it alone, and we sometimes do that. Is the CVEC system the most successful? No, I wouldn't say that. That is yet to be proven. It's relatively new. It's been around for a couple of years, but it's one of my favorites for specific cases, and it's not for every case. So it depends upon the circumstances, and it's something you should speak with your doctor if you have a particular stone that you want to have removed. Not every stone is appropriate for it, but it's good for a lot of the kidney stones and not the really, really big ones. So let's talk about the really big ones. Percutaneous nephrolithotomy is the next line of therapy. It's really one of the more invasive types of procedures that we do for kidney stones. It's something that I love to practice, one of my favorite operations, to be honest. But I do a lot of them, and I was trained by one of the people who was a pioneer, in developing this operation, because prior to that, about 35, 40 years ago or so, it was still common to do something called an anatrophic nephrolithotomy, which I've never seen performed because it's completely outdated. But it was where you made a huge incision on the side of the patient, dissected down to the kidney itself, and filleted open the kidney in order to remove the stones, sewed up the kidney, closed the patient up, and the patient stayed in the hospital for a week or two recovering. It was a big operation back then. But now we do this through a very small incision on the patient's flank area in the back. Some people do it from an approach a little bit more towards the front. And we make a small hole that we can balloon dilate into the kidney so that the scope can go directly into the kidney, fragment the stone, suction out the pieces. It's done under general anesthesia. Nobody would want to be awake to have this done. But the way that I do it, most of my patients go home the same day. Some places they do stay overnight. Some people leave a tube sticking out of the back overnight, or even sometimes a couple of nights. I very rarely do that now. We've really evolved this operation to where it's less invasive, and it's very successful for large stones. Again, not every stone is amenable to it for various reasons anatomically, but it's a good choice for the really large stones. The staghorn calculi we spoke about before, staghorn stones, calculi are stones, and so this is the treatment for those larger stones. And as I said, this is usually an outpatient procedure. Patients can usually return to work within about a week or so. It varies. It also depends upon the patient. I've had patients go back within a couple of days, and other patients who need a couple of weeks off, depending upon how they tolerate the surgery for various reasons. Somebody asked the question, I'll just go back for a moment. Would the laser cause any tissue damage to the kidney? So on the surface, it can do some damage to the lining of the kidney, but that heals itself virtually always. It's rare to cause any real damage with the laser in the kidney. It can cause more damage in the ureter. The ureter is a very flimsy tube, and when we're doing lasers within the ureter, one has to be very careful to try to avoid injuring the ureter. Somebody asks what quantity of water to drink. Again, there really isn't the right answer. I tell people at least 6 to 8 glasses a day, but we really want ideally to produce 2 liters of urine a day, which would actually be a lot more water than that. But sometimes it's wishful thinking to suggest that somebody's going to drink that much. But if you can, it's certainly a good thing to do. So let me show a video of the percutaneous approach. So this is the one with small incision on the back. And there's different ways of doing this. This is not necessarily how everybody does it. This is just one video that I have that I can show it in the cartoon style, how it's done. So you have the 2 kidneys. There's a big stone in that kidney. So the first thing in this particular video, it's they first show a catheter going in, urinary catheter. That's actually a little out of order. The first step would really be what they show next, which is putting a thin catheter up the ureter to the kidney. Then you could put the catheter into the bladder. I didn't develop this video myself. This allows us to inject dye if we want to see the whole kidney. Sometimes we don't need to, but we put that catheter up. Sometimes also to prevent fragments from going down the ureter while we're breaking the stone. We then stick a needle into the kidney. Again, there's different approaches as to how exactly to do that. But once the needle goes in, we can sequentially dilate over that needle by feeding a wire through it, and then use different types of dilators to create a large enough hole to put a sheath or a tube that goes now into the kidney. And through that tube, I can then put a camera to get to the stone. So here's the camera coming out, a little device that can grasp some of the stones. That was a small stone that was just grasped. And here, in this particular one, it's showing it using a laser to break it and a basket. I actually use a different type of device most of the time, which uses sound waves and a little bit of vibrational force, almost like a mini jackhammer that breaks and suctions out the stone fragments. Ultimately, all the stone is gone. And I then do, as this video shows, I feed a stent most of the time down the ureter. This helps any blood products from clogging, prevents it from clogging the ureter, or any little fragments that you inadvertently did leave behind from getting stuck on the way down, while the hole on the patient's back and the kidney seals up, and then the patient goes home. And then I take out the urinary catheter before the patient wakes up, and that stent stays in them usually for a week or 2 after the surgery, and they come to my office for it to be removed. So that's really it. Again, this is a general overview. I strongly recommend anybody who actually has stones that they speak with their own urologist about their particular nuances, both how to prevent their stones, what medications are appropriate for them, and as I said, but all stones are different. Every patient is different, but there are a lot of different treatment options. I recommend you speak with your urologist at advanced urology centers. We have practices all over the New York area, so hopefully one of our offices is in close proximity to you to take care of you if you're not already seeing one of our urologists. And I'm going to look at some of the questions here, try to answer a few of them before we call it for the evening. So I see one question here is, which procedures do not require a stent? So the answer is, it depends upon the surgeon doing it. Not everybody practices the same way. I leave a stent for most of certainly my percutaneous procedures and virtually all of my ureteroscopic procedures. ESWL, extracorporeal shockwave lithotripsy, most of the time does not need a stent, unless it's a very large stone and we're worried about fragments getting stuck on the way down. So then we usually do leave a stent, but it depends upon where the stone is located exactly, and that's a nuanced answer that would depend upon the particular patient and stone. Are lower pole stones best removed with a certain method? No. The quick answer is no. All 3 procedures are theoretically good. Success rates are going to differ because lower pole stones can sometimes be more of a challenge, but with the new technology to get to the stones with the ureteroscopy, you can get to them. It depends on how big the stone is, which procedure is the right one, and exactly where in the lower pole, and if there's any other anatomical things to worry about. Somebody wrote how much pain with that. I'm assuming that was based upon the last part of the presentation, which may or may not have been true. I don't know when that was asked exactly, but after a percutaneous procedure, it is a small incision. We do go through the muscles, so it can be painful, but I don't know that it's more painful than having to pass fragments. So I think it varies a lot from patient to patient. I do give my patients painkillers after the operation, of course, and most patients tolerate it very well. But the stents can also be painful, and so that's again, varies tremendously. Somebody else, does liquor have an impact on developing stones? So alcohol in general is actually functions almost like a diuretic. It causes us to produce more urine and often helps stones pass in some circumstances. I would never advocate that somebody's drinking alcohol as a therapeutic option to manage a stone that's passing, but I've never seen any reports that have shown liquor making it worse for developing stones. But might they help pass the stones? Maybe, but again, alcohol intoxication is certainly not what I'm prescribing here. But I think if I answered your question correctly, I don't think it causes any stones to develop. Let's try to go up to some of the older questions that were sent in first or earlier on. Let's see. So somebody asked, is it true that if you drink a certain amount of water, does that prevent stones from ever even forming? I mean, it probably is true for some individuals. This particular person was told if he drinks 82 ounces a day for themselves, that a kidney stone can't even form. That may be true. 82 ounces of water is a lot of water. Obviously, also it depends upon your medical conditions. If you have any other medical conditions, got to be careful drinking that much water. There is such a thing as too much water, but not for a young, healthy person in most cases who has a good heart and good kidneys. But yes, if you drink enough water, theoretically, that should help prevent kidney stones. What is enough water? I think, again, it depends upon the individual. So something you should discuss with your doctor to get the particulars. Again, if somebody asks if I'm prone to getting stones, is there any medicine that can be given to help prevent? So to answer you generically, citrate supplements is where I would start, and hydration, avoiding salt. But then knowing what types of stones you have definitely makes a big difference. The longer answer is, again, somebody who's really worried about stone prevention. I see there were a few questions about nuances of particular medications and different types of supplements of what somebody can and can't take or should and shouldn't take. A nephrologist, who's a medical doctor for the kidneys, is really going to do a thorough metabolic evaluation. As urologists, we often do them as well, 24-hour urine testing, but a nephrologist is often going to be even more thorough. Again, it depends upon the urologist and it depends upon the nephrologist. But for somebody who's really worried about stone prevention, I would encourage you to see a nephrologist as well as your urologist. The nephrologist will really focus on the metabolic problems and the prevention, and the urologist will function more as the glorified plumber, as your surgeon when you need to have a stone taken out. Of course, we can monitor the stones with you. Many of us do ultrasounds in our office also to monitor stones, but it varies a lot. Somebody asked a particular question about themselves, that asked about how long can a stone take to pass. That's 3 and 4 millimeters. And it says, my urine is cloudy, but I'm not in pain. I've had them since November. So the answer is it varies. It depends upon where those stones are. 3 to 4 millimeter stones in the ureter, I wouldn't let it sit there for that long. From November till now, I'd be worried that at some point the kidney will get damaged from a stone sitting there for that long. When the urine is cloudy, I worry is that the possibility of it being an infection. And if there's an infection and the stone gets stuck, again, that can lead to sepsis. So it can be dangerous. And so it's something you should definitely speak with your particular urologist to look at your kidney, look at your stones, and discuss with you. But they could sit there for years and years and years and never pass if they're sitting up in the kidney in a non-threatening place. I'm just looking through some of the questions here. What does potassium citrate do? So potassium citrate raises the pH of the urine. It alkalinizes the urine. So it's utilized mostly, and not exclusively, but mostly for uric acid stones. Uric acid stones develop in acidic urine. We want to change that acid to a base, and potassium citrate does that. It changes it, it raises the pH of the urine. And there are particular levels that we look for. Again, it depends upon the individual. We don't want to overshoot. If you get too high of a pH with it, then you're more predisposed to a different type of stone called calcium phosphate stones. So you have to be careful with it. It should be monitored, and but if it's prescribed by a physician, then hopefully they're monitoring it properly. All right. So what medication can dissolve uric acid stones? Another question here. I think we just answered that. The potassium citrate is utilized to do that. Some people are put on allopurinol to help prevent the buildup of uric acid, but to dissolve it, which was the question, it's potassium citrate. Somebody asked about supplements. I think I answered that before. Citrate supplements, something called polycitra, or Therolith, and let's see what else we have here. But those are citrate supplements. But Therolith is a common one through Theralogics. They have two different types of products that have high citrate. It helps prevent all stones. One's in a pill form, a packet of powder. Another one comes in a pill form. Let me just see. I answered that question about ultrasound causing damage. How does one determine what type of stone is present? So, first of all, if it's surgically removed, we can determine what type of stone is present by having it analyzed. If it's not surgically removed, so we can't always answer that question. Uric acid stones that we talked about don't show up very well on x-rays. So if somebody has a decent sized stone, tiny ones, even calcium stones, may be missed on an x-ray. But if you have a decent sized stone and you do an x-ray and you don't see it, the most common one then would be a uric acid stone. If you do see it, it's probably a calcium-based stone of one form or another, but it doesn't tell you necessarily which type. There can be calcium oxalate, and even calcium oxalate gets broken down into monohydrate or dihydrate, and calcium phosphate is another type of calcium stone. But there are other types, and struvite stones we talked about would show up on an x-ray, so the urologist would obviously have to work with you to try to see if there's a way to find it out, but sometimes you don't know until you actually have a procedure to remove it or until you pass a stone. All right, let's see. I answered most of these. How often should you get a blood test to monitor the potassium, and is it dangerous to have high levels of potassium in your blood? Yes, it's dangerous to have high potassium levels in your blood. Too high potassium can be bad for the heart, and even acutely cause a problem if it's really high. So it depends. I can't really answer you how often it should be checked because it depends upon how high it was to begin with, how the kidneys function. Are we worried about levels not being adequately monitored in a given individual whose kidneys aren't all that great at getting rid of the potassium? So it does vary from patient to patient. Hard to answer on a webinar like this. It's something you should discuss with your urologist if they're prescribing the medication. If it's not a urologist, a nephrologist certainly is capable of also telling you how often to have it checked. But whoever's prescribing the medication should be telling you how often to check it. And again, I think the same person asked the question, is everyone a candidate for that procedure, all different types of stones? So no, all different types of stones are addressed differently in a given individual. This was a broad overview. Again, lithotripsy, usually utilized for stones sitting up in the kidney. It can be used for stones in the ureter as well. We don't do it for stones that are too big. It may not work that well. If they're uric acid, hard to see them, but you can do it under ultrasound guidance, but it's more complicated and not always as successful because you don't see them, but they're softer. So if you do hit them, then they break fairly easily in most, but not all instances. Ureteroscopy, if the stones are too big, can be too difficult to remove, and you might need the percutaneous procedure. We don't use the percutaneous procedure for smaller stones typically. All right, I think we answered a lot of this already. Okay, what happens if the wire going up that very narrow passage pierces something? So it's not a good thing if the wire pierces something, but thankfully the wires are very, very thin, and if it does pierce something, meaning goes out the ureter, it makes a hole in the ureter, that typically will heal. We generally leave a stent because that'll allow the ureter to heal in a nice open position. It's very rare that it pierces it though. Most of the wires that we use today have a very soft and floppy tip. It's not a sharp tip at all. And so the rest of the wire is a little bit more rigid, but the tip of it is very flexible and floppy. The most common one that I use, and I think a lot of urologists use, is something called a sensor wire. And the sensor wire has a very floppy tip with a more rigid body. So when you feed it up, it easily goes up the passageway up to the kidney and causes virtually no trauma. I'm not saying it can never cause it. It depends upon a person's particular anatomy, but it's usually very, very safe. So again, but the urologist who's using it should certainly know how to handle it if he sees that it goes in the wrong place. It gets pushed out. Maybe when it hits the stone redirects the wire and it pushes it out the ureter. It can happen. Rare, but it can happen, and the urologist should know how to manage that situation. What do I consider a large stone? So it's all relative. The large stones in the kidney. So we generally say a stone. Again, it depends upon what we're talking about doing. If over 2 centimeters, they're generally going to recommend a percutaneous nephrolithotomy. That doesn't have to be done. It depends upon the stone. Sometimes you can still have that CVAC procedure with the vacuum. If it's not too hard of a stone, it can be managed with that. And even lithotripsy can be used for stones of that size. So there isn't a particular size. It depends upon the patient's anatomy, where exactly the stones are. And again, it's a relative term that we use. For the ureter, a stone that's 7 millimeters, I would say, is fairly large. That's going to be hard to pass. 5 millimeters has got probably a 50-50 chance of passing. When it's already halfway down, it still only has about a 50-50 chance of passing. So even a 5 millimeter stone often does get stuck. 7 millimeter is more likely to get stuck than not. But that's if it's in the ureter. If it's sitting in the kidney, I wouldn't say it's necessarily a large stone, but a little bit potentially too large to pass in many circumstances. So this is actually a great question. What if you only have one kidney and the stone? So it definitely makes it more complicated. I just recently had to do a percutaneous nephrolithotomy on somebody with only one kidney. I hate doing that because God forbid you have a complication. They don't have a reserve for the other side. So if you leave a fragment behind and after you take the stent out, that fragment gets stuck, they don't have another kidney to help get the urine out, and that can be very dangerous. So if you have a stone sitting in the ureter of a solitary kidney, when somebody only has one kidney and the stone is stuck in the ureter, that's an emergency. That person's usually not producing urine, and they're going to go into kidney failure very quickly. So when they're in the kidney, we also talk about how do we take care of them before they get too big, because we don't want them to get stuck on the way down, and sometimes we do have to do an elective procedure on them. But in a similar vein, I don't like doing an elective procedure on somebody who only has one kidney. So it's definitely a dilemma. It can be a real challenge. So it's something you need to discuss with your urologist. If that's in reference to yourself or a family member, they should be under the care of a urologist who's monitoring their stone very frequently, if not talking about preemptive attacks on the stone. So we asked about the stent. I think I mentioned that before. Which procedures do not need a stent? I answered that before as well. Okay. So if any of these methods are making their way to the Midwest, I live in Minnesota and have suffered from stones for 20 years. I've never heard of these types of procedures. That's surprising. I don't know the answer. I don't know where exactly you are within Minnesota. There must be some tertiary care centers. I would look for big university centers because all of these procedures should be performed in all 50 states. I'd be surprised if they weren't. But it's something to talk about with your urologist. And depending upon what you have stone-wise, if it's really a complicated situation and there isn't a qualified urologist, I would probably try to find my way to a place where there is an academic center, tertiary care center, where there's somebody who specializes in stone disease. If you don't know how to find that out, you can look up endourologists. Endourologist is usually a term that we utilize for people who specialize in stone disease. Sometimes it can be a general urologist such as myself, who don't necessarily advertise as an endourologist, but that's what we're doing. We are endourologists, and in an academic center, they would usually advertise as that because they try to compartmentalize their subspecialties within urology. So that's what I would look for if that were me in a remote area. All right, let's. Is the removal of the stent in the office done under sedation? Terrific question. So it depends. Most of the time, not. Most of the time is done with lidocaine jelly, a numbing substance for men. Women, not even that, because the urethra in a woman, it's hard to put lidocaine jelly in, and it's a shorter urethra. For women, it's generally better, more tolerable than it is for men for obvious anatomical reasons. For women, they say that it's less painful for a cystoscopy to go in there than a pap smear is. Thankfully, I've never had a stent removed. I've never had a cystoscopy, and I certainly have never had a pap smear, so I can't vouch for that, but that's what I've been told. But in terms of your question, is it done under sedation? So sometimes it can be. I took one out under sedation in my office yesterday for a patient who just couldn't have it done any other way. But usually it's not necessary. And there are offices, again, such as mine and many other urologists within Advanced Urology Centers of New York, where we've now offered nitrous oxide, Pronox, which is basically a substance to relax the patient adequately. So for this 2-minute procedure, rather than having to undergo full sedation, because full sedation gets more complicated. You need to have an anesthesiologist. Not every urology practice has an anesthesiologist that can come to their office. It's complicated to have an office certified to have anesthesiologists come in. So many offices don't have that capability. So it's often not done that way, but it does depend upon the patient, the doctor, and something that has to be negotiated or at least discussed with your own doctor. Can a 7 millimeter non-obstructing stone in the right lower pole be left alone? The answer is sometimes. And the answer is yes, it can be, but it depends upon the situation. If it's developed over a short period of time, you can only imagine it's going to continue to grow and become more of a problem as time goes on, because then the procedures are going to be more invasive to get rid of it. And the patient has to understand that if this stone does move, it may not be able to pass. It can get stuck and be extremely painful. And so you might want to deal with it preemptively with a shockwave lithotripsy to try to blast it before that happens. Of course, you run the risk then that the fragments get stuck on the way down. So I can't say that it's without risk for the treatment or for leaving it alone and doing observation. So again, something worth discussing with your urologist and talking it through and seeing what you mutually agree upon is the best plan for you as an individual. So there's certain foods that cause stones. I think we hit on that when we talked about oxalate-rich foods or protein-based foods, depending upon the type of stone that one is predisposed to. Salt can cause all types of stones. So high salt content doesn't mean you can't have any salt, but hydration hopefully counters a lot of this stuff. So increased hydration, increasing the citrate intake can, again, generically answers the question of what to do to prevent them, as I've mentioned a couple of times through this talk. I've had ureteroscopy and lithotripsy and still get stones. Should I see a nephrologist? I certainly would. I think it's worthwhile. A good nephrologist who sees a lot of stones should really be working with you to help prevent them. I'm a urologist and I take care of a lot of stones, but when I have somebody who has recurrent stones, I often bring that up as something to consider because there's no reason why you should have to keep coming back to my operating room. And so I would encourage you, yes, to see a nephrologist. It is worthwhile. If you don't have one, you can either ask your urologist to help you find one, or your internist can certainly make a recommendation to a good nephrologist. Most nephrologists would be comfortable dealing with stones, but if you can find one that does a lot of stone disease, even better. Somebody asked if high fiber diet helped prevent stones. I've never heard of that. High fiber diet is more for bowel things to help the gut. Now, whether or not it will prevent malabsorption things, I've never heard of that being the case. But if somebody has a lot of diarrhea, for example, so then maybe high fiber would help with that because it'll bulk up the stool, prevent all the extra water from getting lost in the stool. As I mentioned before, significant amounts of diarrhea can predispose somebody to developing stones. So I would think that in that case, high fiber might be beneficial. It's probably something where your gastroenterologist and maybe together with your urologist should discuss how to best manage that particular situation. Have there been many fatalities due to kidney stone procedure? Well, thankfully not. It's extremely rare. The times that fatalities occur is when there's sepsis, if there's a bad infection. Thankfully, even in that setting, it's rare. Usually it's a sicker patient that happens to. It's rarely going to be a younger, healthier patient that can happen to. I won't say that it's never happened. I'm sure it has, but thankfully that's extremely rare. If you're asking about the procedure itself causing a fatality beyond stirring up an infection where there's already an infection in the urine, and for that reason, by the way, we always check before doing procedures if there's an infection, but extremely rare. The percutaneous one can cause bleeding, but rarely enough to be that dangerous. There are ways of dealing with bleeding when it happens, and it's very rarely that kind of bleeding at all. But has it ever happened? I'm sure it has, but again, extremely, extremely rare. And so that's not really something that's on our radar to even be concerned about when we talk about operating on kidney stones. Okay, let me see any other things. Liquids like cranberry juice, can they be helpful? So cranberry juice is something that we talk about more for preventing urinary tract infections. And I believe that cranberries actually have a moderate amount of oxalate in them. Again, the liquid content probably counters it to a large degree, but cranberry juice is not generally considered the go-to drink for prevention of kidney stones. We're going to wind down now because we're nearing 8 o'clock, and so I'm just looking to see if there's any other question I can answer fairly quickly. What size is too large for the new surgery? So I think if you're asking about the question about the CVAC, the one where we suction out the fragments, so there really isn't a size criteria. That's something that the urologist has to look at the stone and see if they think it's feasible. A very hard stone that's 1.5 or even 2 centimeters. Many of us won't want to do it because it can be challenging, whereas you can deal with it percutaneously much more easily. But I did do a stone this past week with that procedure that was, I think, 1.7 centimeters, and I got the whole thing out. So I don't know if there is really an answer to that question that's what's too large, but I think it depends upon the particulars of the situation. With that, I apologize. I can't answer every other question on here. There's just still a whole bunch more questions, but I was told to keep it to 1 hour. So I would recommend that all of you here, certainly if you live in the area, see a urologist within Advanced Urology Centers of New York, because we deal with a lot of stones as a group. We have offices, like I said, all over. On the screen here, you can find locations that are close to you. You can click on them and find one that's close to you. If you already have a urologist within the group, then discuss these questions further with your urologist, because there's a lot of great questions here. I'm sure there's more if we give it more time that would come up. And it's been an honor to speak to all of you. I thank you all for your time, for coming out tonight, and I wish you all the best, and hopefully figure out a way to prevent your stones for the future. Have a great evening, and again, thank you for joining.